course. But on the other hand, we do use them, antibiotics. Colonized and infected wounds are a reservoir of potential pathogens and may lead to cross-contamination. If the host immune system fails, colonized wounds will become infected. And these chronic wounds have increased tendency to colonize or to colonize drug-resistant organisms. So we have to use them. We can use antibiotics systemically with all its limitations, or we can use antiseptics topically, again with all its limitations, or both. We'd rather start with antiseptics because of resistance, because of reaching the site of infection. As I said, all these wounds, or most of these wounds, are ischemic in nature and blood supply is very limited. And antiseptics, of course, have a much broader spectrum of activity. Basically, an optimal antimicrobial dressing would be effective against likely contaminants and pathogens, of course, and kill microorganisms also in biofilms, reducing the biofilm mass simultaneously. Would act quickly and for a long period of time, would of course be inexpensive. There would be no resistance, minimal systemic absorption, and of course, ideally, non-toxic to human cells. A cost-benefit. Having said this, let us have a quick look at the most important antiseptic agents that are used in wound healing today. When trying to design antimicrobial agents, we want to have a sufficiently high concentration to have all microorganisms killed. Unfortunately, a high concentration goes hand in hand with a high toxicity. Like Paracelsus many centuries ago already said, the toxicity of a product is decided upon by its concentration. Only the concentration decides upon toxicity. Nevertheless, we want an antimicrobial agent that acts quickly and for a long period of time. Initially, we have been using antimicrobial agents that got very quickly into solution, and we used them at a high initial concentration. In recent years, we've been modifying old antimicrobial agents into new ones, which have a kind of slow release profile. Now let's have a look at them. You know them basically. Iodine was used formerly as iodoform alcoholic potassium iodide, or Lugol solution, which is more soluble and has a higher concentration. Disadvantage of these ones was that you had to start at a relatively high concentration. It acted quickly, but it disappeared also quickly, which meant that in the beginning, having a high concentration, you also had a high toxicity. So we changed the profile of these iodine-based antiseptics, and we've tried to encapsulate them in large polymers that would slowly release iodine into the environment if moisture is present. The best known is PVP iodine or betadine, there are several commercial brands. Again, it has been developed as a pre-surgical skin antiseptic. It's only later that they have been using this in wounds. The other one is based on a starch polymer, cadexomer. Iodine is bacteriostatic and bactericidal, both. And today we only use these slow release forms. They exist as ointment, as dressing, as solutions, as powder, and as spray. Iodine will react with thiophenol and phenol groups of amino acids of proteins and destroy them. And this way they might also react, at least if they get into the cell, with DNA. And that's how they kill bacteria. Today it's one of the mostly used antiseptics that we know in wounds. Another one which is very, very important is silver. Silver compounds have been routinely used as an antiseptic for more than a century. They impair electron transport system of bacteria, but not only of bacteria. Silver impairs electron transport systems, both of bacteria and human cells, and this explains also their cytotoxicity. Silver nitrate was the first silver compound used on wounds. Today it's only used occasionally to reduce hypergranulation tissue because it's so toxic. It just kills the hypergranulation tissue. Esterification with sulfadiazine has resulted in a widely used antiseptic, SSD, silver sulfadiazine, mainly used in burns but also in chronic wounds. And recently a number of silver-containing modern dressings have become available. The aim, again, of the incorporation of the silver into the sulfadiazine or the incorporation of silver into this dressing is a slow release so that we can start at a lower concentration, less toxicity, and keep this concentration constant over a longer period of time. In any formulation, the way silver is released, its bioavailability, so to speak, or the concentration that will be built up in the wounds, this concentration will determine the activity as well as the toxicity of this product. Activity and toxicity inevitably go together. The antimicrobial active agent is silver ion. In solution, whether it comes from silver sulfadiazine or from another dressing, it's the same silver ion. The concentration that is released will determine the activity and at the same time the toxicity. Less used but also worth mentioning is chlorhexidine and polyhexanide. Chlorhexidine is today again mainly used on intact skin. It's an interesting product because it binds to the stratum corneum and remains active when put on intact skin for at least 6 hours. So they use this a lot in hand washing and skin scrub products. And finally, less used today is Daquin hypochlorite solution because of its cytotoxicity. Recently, another product, and I'm in Australia here, so you will know this better than I do, is honey. It's of course an ancient remedy. It has been rediscovered for treatment of wounds. Why has it been rediscovered? Because now we've been able to differentiate the different kind of honeys according to their antimicrobial effects. And there is one particular honey, Manuka, so the New Zealand tea tree honey, which is proposed for the treatment of acute and chronic wounds because of its antimicrobial activity at least. Why? Because of osmolarity or acidity or the generation of hydrogen peroxide due to an enzymatic system based on glucose oxidase, or the presence of new unknown antimicrobial compounds. The Germans have identified methyl glyoxal in honey as an antibacterial compound. Basically, we don't know. There are probably several compounds, but it works antibacterial. It has an antibacterial activity. On the other hand, the geographical location, floral origin, and post-harvesting treatment conditions may also be important in building up the antimicrobial activity, and this limits to some extent its use in wound care because there is still a lack to standardization, although we're all working on it. So their use is limited, and this is why I would like to present you a new modified honey concept, which starts from chemically compounds. We start with the same glucose oxidase, which is found in honey, on one hand. We add another enzyme, lactoperoxidase, and finally we add a third compound, which is guaiacol. Why? Because the concept of using an oxidase enzyme combined with a peroxidase enzyme greatly enhances the antimicrobial activity of the glucose oxidase. Basically, this enzyme system produces an oxygen radical. Oxygen radicals are very much unstable, so stable for a very, very short period. However, if we